welcome to EuroPCR 2024. My name is Davide Capodanno. I'm so glad to be here with Antonio Colombo and Stefan Varaille to discuss drug-eluting stents, because sometimes we give for granted that these are good devices, but there are still some events at 1 year at least, but also beyond. So there are no better speakers today to tell us about the past, present, and maybe future of this technology. And Antonio, if you agree, I would start with you and ask you what are, in your perspective, a very important perspective, the current limitations of drug-eluting stents?
Well, drug-eluting stents are still a stent, which is a permanent device which stays as it is as at the time of implantation. The vessel is not really a permanent tube, has the capacity of remodel like a Glagov, and has the capacity to pulsate systole and diastole. And these two features are totally negated by a permanent metallic implant, even if it's drug-eluting. And this fact may have an impact, not necessarily at 1 year event, but when we extend the follow-up to 3, 4, 5 years.
Okay, so the caging of the vessel, it's an issue.
It's a limitation.
And maybe I can ask Stefan, so we are taught that stents are made of a platform, a polymer, a drug. So which of these aspects, if anything, we can improve?
Well, Davide, I'm glad you mentioned already the word caging, because that's what we currently do, as Antonio mentioned, with the caging elements. And what we have now today with this device is that there is some uncaging elements. So it is a metallic platform. It's made out of cobalt chromium, 3 helical strands, and it has distinct uncaging elements that are with a bioresorbable substance, and they bioresorb over 6 months. So in other words, the uncaging elements allow the stent to modify to the vessel itself, and therefore this is still with metallic. You have a scaffold, you have a bioresorbable uncaging element, and you have the drug.
Okay.
So that's really a novelty in stent design.
So if it is novel, is it correct to say that this is a stent, or we should call it in another way? So what is the correct term?
So it's like they call it a bioadapter because it adapts to the movements, the physiological behavior of the vessel, so to say. It allows vasomotion capabilities.
Okay, and this may address the issue that Antonio has commented. But at EuroPCR this year, we have the 2-year data of the Bioadaptor randomized clinical trial. So last year, we have seen the 1-year results, and the stent, the Bioadaptor, was shown to be non-inferior to a comparator in the benchmark of the best DES. And now we have the 2-year outcomes. So what are the novelties?
Well, the novelties that we see at 2 years are actually exactly what we were hoping for. As Antonio mentioned, you have a plateau, an increasing 2 to 3 year percentage of events every year. And so what we did see now in this trial, that at 2 years, we actually remain at a plateau. So the event rate was 1.8 at 1 year, TLF, and at 2 years we have 1.9. Versus the comparator increases, which leads to a 65% reduction in TLF rates in the overall population. So that's a significant reduction in TLF rates.
Okay, so this is more than encouraging, because it shows that if the concept works, you expect this curve to become flat, which is something at 2 years we start to see. But now going into practice, because this is a stent, a Bioadaptor that we have already on our shelves in some centers. So I would like to ask Antonio Colombo to tell us who are the ideal candidates to start with and to gain some experience.
But we in Humanitas have been conducting a prospective study for the past 2 years, utilizing this device in complex lesion, the Bioadaptor in complex lesion. Complex lesion, I mean total occlusion, long LAD lesion. And we have OCT as the baseline, and we will perform OCT as the follow-up. And I really believe that the quality of these devices are better expressed in long lesions where a permanent caging may be a problem. In very short lesions, maybe a jump can be done, but in long lesion, a jump is more difficult for the blood to maintain all the characteristics of the vessel elasticity. So I think in long, complex lesion, this device is appropriate. As far as the implantation technique is exactly the same as a metal DS.
Okay, so thank you for this advice. I don't know, Stefan, if you have other candidates to be considered?
Yeah, what I would like to add, especially based on what we've seen in the 2-year data now here, is that the fact that in LAD lesions, you have a 78% reduction in TLF, which is unseen and unheard of, compared to the comparator, an almost 80% reduction in TLF. So that's significant. And if you look at TVF, at target vessel failure, you also lose a 65 or a 68% reduction compared to the comparator. So basically these, I would say LAD lesions, long lesions like Antonio said, younger people, those are the ones where you have this possibility. And especially those vessels where you have most rotation, LAD, RCA, those are prone to have more events. And I think that's a suitable platform for that.
Okay, thank you for sharing with us this information. I think it's a good teaser also to what next for this device, because the Infinity's Withered trial will be presented soon, and this is a large-scale study comparing in a proper manner with big numbers and, of course, more events, and to challenge this device versus the contemporary DS. So we look forward to have this data in order to know more, but we feel encouraged by this data because they are going in the right direction. So thank you very much for watching this video. I hope you enjoyed it, and thank you so much for attending.
Thank you. It was a pleasure.